Professor Nabil. Thanks to Professor Qutaiba and all the audience. I'm going to try to share my my slides. Am I a co-host at the moment?
Yes, Professor Doctor, you should be able to share.
Can you see the slides?
Yes, Doctor.
Yes, you can. Okay,
Yeah.
that's great. That's fantastic. Okay, so I'll put it in display mode. Can you see the slides now?
Yep.
Great, fantastic. So today we're going to talk about tackling the challenges of disturbed sleep. And before starting my topic, I would like to just congratulate everybody for the great achievement of the UAE reaching to Mars. And if you've had no sleep last night, that would be no sleep of joy. So that's not a problem. But today I'm going to talk about the sleep problems. So the topics that we will discuss, the normal sleep, common sleep problems, and the management strategies for sleep problems. So what happens in normal sleep? When we go to sleep, there are two broad types of sleep that we get. There is the rapid eye movement sleep. That's where eyes are rapidly moving, and as the name suggests. And the other type is the non-rapid eye movement sleep. And usually we go through a cycle of REM and non-REM sleep. And each cycle on average is around 90 minutes. And in a good sleep night, we get around 4 to 6 of these cycles. So what happens when we go to start sleeping? There is stage 1 of sleep. That's when we start to feel a bit drowsy or just starting to feel the sleep starting. So the brain waves become slower, and the muscle activity starts to decrease. And then we go to the second stage, and that's where we call it light sleep, because at this stage, the eye movement stops, the brainwaves frequency and muscle tone is decreased, the heart rate, body temperature all go down. And this is where the muscles start to relax and the tissue grows and repairs. And after that, we move to the stage 3, where we really get the deep sleep, the proper sleep, the sleep that will get us refreshed next day in the morning, will make us feel ready to do whatever we need to do. And in this stage 3, the breathing, blood pressure, and temperature all are reduced. And the body is completely relaxed. And what we see if we do an EEG, for example, that's detecting the waves of the brain, we will see slowing of the brain of those waves from to around what we call delta waves. Now, at some point after stage 3, hopefully, but sometimes people don't have stage 3, they skip to go to REM sleep. And that's where the eyes are moving rapidly, but the skeletal muscles are paralyzed, heart rate, blood pressure, respiration, all going variably up and down. That's when we get the sexual arousal. It's a good time to make a baby. REM sleep usually takes up to 20 to 25% of the total sleep time. And this is where we get dreams, whether these are good dreams or sometimes bad dreams like nightmares. So that's what happens in the normal sleep cycle. And this is just to show you how we perceive a good night's sleep of, say, 8 hours, where we get at least 2 cycles of deep sleep, stage 3 and well, I didn't mention this, but stage 3 and 4 are usually combined together as stage 3, depending on which reference you use, and at least you get 2 periods of stage 3, and that will get you good night's sleep, but you will get those ups in the REM sleep in betweens. So the sleep can be disturbed in many ways, and I don't think we will have time to discuss this today. Otherwise, we'll have to stay until tomorrow, and you will be sleep deprived completely. So we will focus on the main issues, the common issues, and we'll keep other things maybe for the future if we have the opportunity. Insomnia, very common. There are sleep-relating breathing problems, and then the central disorders of hypersomnolence, the circadian rhythm, sleep-wake disorders, parasomnias, sleep-related movement disorders, and other type of sleep disorders. So today we're going to focus only on insomnia, but we'll mention in passing some other disorders. So insomnia is a condition of unsatisfactory quality and or quantity of sleep, with the difficulty of falling asleep, remaining asleep, or waking up early. So it can be initial insomnia, you try to sleep, you can't sleep. It can be mid-sleep insomnia, you wake up, you stay for hours until you are able to go back to sleep eventually, or it will be early morning awakening. But even if you sleep a lot and still don't get the quality, that will still be called insomnia. And it's a very common complaint in the general population. Around a third of the population will complain about difficulty with the sleep, about insomnia. It's more common in females, it's more common in the elderly, and it's particularly more common in the clinical population. So people who attend the general practitioner, the doctor in hospital, and the psychiatrist, they're more likely to have sleep problems. The clinically significant insomnia, it's around 9 to 12% in the general population. So it is a common problem, as you can see. Why do people get insomnia? If it's transient, it might be just because of stress, or because someone has just traveled long distance, so jet lag. People, doctors who are doing night shifts, or any professionals who do night shifts for a few days, they struggle to get off to sleep when they are outside this phase of working at night. But also short-term insomnia can be associated with illnesses, with bereavement, relationship difficulties, or stress at work. And people sometimes ask, do you get sleepless night, and what keeps you awake at night if you do a certain job? And Professor Qutaiba gave a talk a couple of days ago about why bother doing research and when should you stop doing it. And I think if you're generally having sleepless nights because of work that's sustained, that's really, it's been for a long period of time, you have to change something about the way you work, because you're not going to be productive and efficacious in what you're achieving. So the sleep onset insomnia can be a relatively common complaint among adolescents. So this is for parents to observe. Yeah, it's not unusual. And insomnia in clinical practice can be secondary to other conditions like pain, any type of pain, depressive disorders, anxiety disorders, dementia, psychotic disorders, excessive use of alcohol or caffeine. And here it's not just coffee, so coffee, tea, energy drinks, anything that, Coca-Cola, for example, anything that contains caffeine, and also prescribed medication. Some of the common prescribed medications that can cause insomnia: antidepressants. Certain types of antidepressants can cause insomnia, like SSRIs and SNRIs. So an example of an SSRI would be fluoxetine, sertraline, citalopram. These all, you have to be careful not to prescribe them at night or at bedtime, because they can cause insomnia. SNRIs, like for example venlafaxine, would be the same. But sometimes you do prescribe them late, but that has to be weighed with based on really good judgment why it is the case. Anti-Parkinsonian medications, dopamine agonists, bronchodilators like theophylline, cardiovascular medications like beta blockers, corticosteroids, stimulants like amphetamines. These, for example, this dexamphetamine that's prescribed for ADHD. Levothyroxine is a very common problem, hypothyroidism. So, make sure you take it in the morning if you're prescribed it. Cholinesterase inhibitors for dementia, like donepezil, galantamine, rivastigmine, and so on. So this is not an exclusive list. There will be a much longer list. So it is about the clinician to discuss this with the patient and prescribe at the right time. Now, with chronic insomnia, chronic insomnia is the difficulty that starting the sleep, waking up early or waking in the middle of the sleep, like we mentioned, but it is associated with other symptoms, and it needs to happen at least 3 days a week for at least 3 months to call it chronic insomnia, according to the DSM criteria. So if you are not sleeping at night, you're going to feel fatigued in the daytime. You're going to find it difficult to concentrate on your study or work. You may have daytime sleepiness. I just remember that, there's one of the sayings in Arabic, مكتوب على ورق الخيار اللي بيسهر بالليل بينام بالنهار. Behavioral problems: you can be irritable if you've not slept well. It can impact on your social life, your family life, your academic performance. And that's where we call it chronic insomnia. How do we do the assessment? We really need to get a proper history to understand the sleep-wake cycle. Are there any factors that improve the sleep? Any factors that worsen the sleep? How does it impact on mood? And what's the relationship here? It might be that someone is depressed and not being able to sleep, or it might be that someone wasn't feeling depressed, but they haven't been able to sleep for a while, and that made them irritable or even feeling sad. How it's impacting on the functioning, past treatment, present treatment, what other over-the-counter maybe medications or drugs they use, do they drink alcohol? And then you can get the history from the bed partner to see whether they're snoring, whether they keep moving their leg, to identify and rule out other causes. You can have a sleep diary where you ask the patient to record how they have been sleeping, and usually we do that systematically for 2 weeks or longer if we are considering chronic insomnia disorder. You can do investigations like video recording Actigraphy, that's a device you can wear on your wrist, and nowadays we have smartwatches, Apple watches you can use for that. Polysomnography, you can check for HLA typing, CSF, orexin levels, which can be indicated in certain sleep problems. So the guidance from the British Association for Psychopharmacology, which was published recently in 2019, that when someone complains of sleep, you check for difficulty going to sleep or staying asleep with impairment of daytime functioning. And if the answer is yes, then you're going to move into what if there's any intake of sleep disturbing substances, and if the answer is no, then you go into diagnosing insomnia. But if there is excessive daytime sleepiness, then you need to think, is this because this person is so tired, or do they have snoring problems, and do they have restless leg? Do they have sudden sleep attacks with cataplexy? And then in that case, you may want to refer to a specialist. So a good way of screening for other sleep disorders. So I said we don't have time to cover all the sleeping disorders, but I'll mention some of those names and how to ask about them in the history. So the obstructive sleep apnea syndrome. Are you a heavy snorer? Does your partner say that you sometimes stop breathing at night? In the case of restless leg syndrome, when you try to relax in the evening or sleep at night, do you ever have unpleasant restless feelings in your legs that can be relieved by walking or movement? By the way, restless leg syndrome is underdiagnosed. It's quite common, and it can have impact on the quality of life of the patient. Narcolepsy, you can ask the question, do you sometimes fall asleep in the daytime completely without warning? Do you have collapses or extreme muscle weakness triggered by emotions, for instance, when you're laughing? The circadian rhythm sleep disorder, do you tend to sleep well, but just at the wrong times? So you're getting enough, maybe hours, it's just you're sleeping between 4 a.m. and 12 midday. Or are these sleeping and waking times regular? And the parasomnias is about what else happens during the sleep. Do you have unusual or unpleasant experiences or behaviors associated with your sleep that trouble you or that are dangerous? So these are good screening questions that we can ask the person who's complaining of any sleep problem. And if the answer is yes to these, then a specialist advice would be required, particularly to, depending on what the condition is. Like, for example, if it's sleep apnea, then you need to do the study of the sleep, and you can treat using CPAP, for example. There's a video here. I don't think we have time for it, but I've just put the link here for people if they are interested in watching it. So how do we manage insomnia? What we really need to do first to think about the non-medication strategies and to advise our patients to establish good sleep habits, sleep hygiene. We can start cognitive behavioral therapy for insomnia, CBTI, and it is really effective. There's the stimulus control, relaxation training, and sleep restriction. The sleep restriction would be, particularly if someone having kind of the wrong pattern of sleep, try not to keep them awake during the day, even, avoiding any naps so they can sleep at night. So I'll explain in brief the concept of cognitive behavioral therapy. And in cognitive behavioral therapy, we always think about how our thoughts, our feelings, and our behavior are all interlinked. And just to remind you of the classical conditioning, as you know, the Pavlov experiment, probably quite famous, when the dog started to have more saliva associated with the bell ringing, even where there was no food, because initially after a few times of the food being provided at the same time as the bell ringing. So the same way, if you're lying awake in bed, fully awake, that there will be an association between the bed and being awake, possibly being anxious, possibly being frustrated. So this pairing needs to be reversed. Otherwise, it will lead to more frustration and more anxiety. And if you see the on the right, how insomnia, how beliefs and attitudes, you're worrying, you're worrying about not sleeping, you're ruminating, you have unrealistic expectations. You want to just, go to sleep and immediately sleep because you're worried about what's going to happen if you don't sleep. So you start to have maladaptive habits, spending a lot of time in bed, irregular sleep schedule, daytime napping, sleep incompatible activities, such as, staying in bed and using your phone. This is now becoming very, very common. I think, people check their mobile phone, their social media very often in bed. Inappropriate use of hypnotics sometimes. These all maladaptive habits or behaviors, and that all leads to consequences, fatigue, performance impairment, mood disturbance, social discomfort, and that leads to uh, arousal, emotional problems, cognitive difficulties, and physiological effects. You're feeling tired, you're feeling pain, you can't concentrate. So that's the model, and working on this model and trying to use the stimulus control. So you break that pairing between bed and wake and strengthen the pairing of bed with sleep and falling asleep quickly. So the advice would be, don't use your bed for anything except sleep and the obvious thing. Don't use your phone, don't read, don't watch TV or eat in bed. If you find yourself unable to fall asleep, I know it might sound, here harsh, but you shouldn't stay in bed for 15 to 20 minutes, anything more than that, trying just to go to sleep, because that will not help, and that will reinforce the pairing between bed and wakeness. So get out of bed, go to another room. You're not here supposed to go and engage in any kind of full activity. You can watch TV if you want, but not something that would be, for example, violence or extremely, attracting. But it could be anything boring would be fine. Yeah. Don't exercise at this stage. Don't eat. Don't smoke. Particularly smoking, because nicotine is a stimulant. Uh, and try not to fall asleep outside bed, okay? And then return to bed. And if you don't sleep, you can repeat the cycle. But the idea, he's trying to break the cycle. And this stimulus control is part of what else you're gonna do within the cognitive behavioral therapy for insomnia. So other parts can include relaxation techniques, and relaxation can be the breathing. That's an easy thing to do. You just try to inhale slowly, keep the breath for a little while, hold it for a little while, and then breathe out and focus on the breathing itself. You can do more sophisticated mindfulness techniques, and these basically mindfulness is about paying attention to the present moment, non-judgmentally, and here you care for yourself, you care for others. You can do mindfulness in many ways. You can do body scanning, you can do also breathing using mindfulness, but you can do much more. There is the progressive relaxation, and that's there are certain exercises where you can tense your muscles and relax them in a systematic way. And there is the guided imagery where it can help with the relaxation. So just to summarize some of the advice for sleep hygiene, try to have a ritual of going to sleep. Sleep in a dark room, in silence. The bed needs to be comfortable. The bedroom needs to be well ventilated, so not too hot, not too cold. Don't eat before going to sleep. So try at least to keep a minimum of 3 hours between the last meal and your bedtime. Don't smoke. Don't drink alcohol. You know, some people use alcohol, especially in the West, to help with the sleep. And alcohol has got this interesting effect where it can, because it works on GABA receptors, it can induce the sedation, but has all sorts of other effects on the body. So the sleep will not be comfortable, and people complain of hangover next day. You know, it's common to have hangover after a night out in the UK, for example, if you drank alcohol. You can exercise not immediately before going to bed. Ideally, you want to leave a minimum of 2 hours. You know, if it's a light walk, it's okay in the fresh air. With caffeine and energy drinks, if you want, I mean, I do drink coffee, I like tea, but if I drink coffee at night, I can't sleep. So what I do, because I love my coffee, I buy decaffeinated coffee. I don't think it's as common here in the UAE. It's available, I've seen it, I've bought decaffeinated tea, decaffeinated coffee. But it wasn't kind of a straightforward available. I had to check and ask before I found it. And from me asking my medical students, not many of them were aware of the decaffeinated tea. So I think we need to make it more popular. If you love tea, if you want to drink tea in the afternoon or nighttime, it has to be decaffeinated. The bed needs to be comfortable, good temperature, we said that, go to bed and wake up at the same time, so having a structure, having a routine. Don't use your laptop, don't use your electrical devices, your mobile phone, don't check Facebook, don't particularly comment on Facebook or post at night, because you're not going to be able to sleep, because you're going to be very interested in getting, checking those red signs on Facebook saying that you have notifications, someone answered or someone replied or someone liked what you said. And don't focus too much on insomnia itself, you know, try to relax as we mentioned before. Now, moving on. So I'm just going to check the time. So I think we're doing okay with time. So medications for insomnia. The medications that we do have for insomnia, we have the Z drugs. I'll explain all of them: the benzodiazepines, the melatonin and melatonin agonists, antidepressants, and antihistamines. So the idea is that, don't prescribe until you have done a good thorough history and confirm the diagnosis and establish the cause. So if the cause is because someone is drinking 30 cups of coffee and smoking, then, prescribing them any medication, it may help, but it's not going to be beneficial, particularly in the long term. If there are other causes, you might, sleep apnea, for example, you might not help this person by prescribing, okay? The other concept is that ideally you want the hypnotics to be prescribed for the short term. There will be some exceptions, which I will mention later, but generally speaking, it's for the short-term use, and it's adjunct to other forms of therapy such as CBTI and sleep hygiene. So starting with benzodiazepines. So benzodiazepines were discovered by this man. Does anyone recognize this man? So it was actually at some point, well, it's still among the most widely prescribed medications in the world, but at some point it was benzodiazepines were the most prescribed medications in the world. So I don't know if there are any answers to my question. I don't know about the interactivity of this platform, but Leo Sternbach, or Sternbach, he discovered chlordiazepoxide in 1956, and then he's discovered diazepam, nitrazepam, clonazepam, and many other benzodiazepines. And Valium was the most prescribed medication in the US in the 70s. So it wasn't the way benzodiazepines work. They are allosteric modulators of GABA ray receptors, and as many of you will know, that GABA is the inhibitory neurotransmitter. And the reason why we're saying allosteric modulator instead of saying agonist or antagonist is because they bind to a specific site of the GABA ray receptor membrane complex, which is different from the site where GABA bind to. So there are some other, the GABA receptor has other binding sites. So there is the benzodiazepine, but also barbiturates and neurosteroids. They also have binding sites. So if I explain this, so the GABA receptor, we have the alpha, beta, and gamma units. And the GABA binding sites are between the alpha and beta, and the benzodiazepine binding site is between alpha and gamma. But what benzodiazepines do, they are positive modulators, allosteric modulators. So why do we prescribe benzodiazepines? They have proven to be beneficial in things like anxiety, insomnia, seizures, alcohol withdrawal, and sometimes treating the side effects of other medications. In anxiety, although they help with anxiety, please do remember that this is not for long-term use. It is for short-term relief of severe anxiety. Could be on PRN basis, could be, if it's regular, it could be for time limited until you start the drug of choice for anxiety, which would be, for example, an SSRI. So they have their role in insomnia, but they come with side effects, the cognitive side effects. They can impair acutely learning, psychomotor slowing, and they cause anterograde amnesia. The long-term use can cause persistent cognitive impairment. And measures of cognitive performance show significant improvement following gradual withdrawal in the elderly compared to those who were maintained on benzodiazepines. So even people who have been on benzodiazepine for a long period of time and they have presented with cognitive impairment can still do something about it. But they also cause paradoxical effects, and paradoxical effects is like if you've seen someone who's intoxicated with alcohol, and they can become disinhibited and they can do things that they wouldn't do in normal situations. Similarly, benzodiazepines can cause this inhibition. So if you have someone who may be presenting with anxiety, and it's not a common side effect, but it's something that you have to be aware of, is that it can cause this paradoxical, this inhibitory, or sometimes even agitated effect, and you think it's not working, that you need to increase the dose. Probably not. Probably consider whether this is a paradoxical effect. But the good thing about it is that the paradoxical effect is really specific to the type of benzodiazepine and dose and mode of administration. So if you prescribe, say, lorazepam IM to this patient and they become more disinhibited, you can try either lorazepam orally, or you can try an alternative benzodiazepine. It doesn't mean that you cannot try any benzodiazepine, or you can change the dose. But the main issue with benzodiazepines is the dependence and withdrawal. So in my clinic, sometimes I get people who tell me that they have been on this benzodiazepine or the other, Rivotril, for example. They say they've been on it for 20 years. Okay, so what are we going to do? If I say I'm not going to give you the prescription, I'm risking here someone having a fit, becoming psychotic, becoming acutely confused. So we really need not to abruptly stop the benzodiazepine if it's been long-term use, but we have to do it very gradually and think about how to do it, what would be the best way to do it. So there are some benzodiazepines that are rapid acting and short acting, so they have short half-lives, and some of them have long half-lives. The idea is that especially if they're using more than one benzodiazepine, like some of them are using 3 benzodiazepines, 2 prescribed and the third one they get from the drug dealer. So try to get them to use just one benzodiazepine, and that's just the long-acting one, and in a very, very small increments, reduce the dose. You have to have a patient who's collaborative. You may well have to work with a family as well. But like I said, if someone is being on long-term benzodiazepine, don't just stop it, because they are likely to go and buy it from somewhere else. The idea is that try not to get anyone on long-term benzodiazepine. So these are just for comparison, some of the benzodiazepines, so alprazolam, Xanax. So the equivalence dose here to 1 milligram lorazepam. So Xanax is more potent than lorazepam, and much more potent than diazepam. Yeah, so 10 times or more. And it's rapid acting, and the half-life is short. The main issue is that there's very high level of abuse with Xanax, and it can cause rebound anxiety. So you prescribe it for someone with anxiety, and you get them coming back to you saying that the anxiety improving with the drug, but I have to take it. So this is likely to lead to addiction. So you have to be careful with this. Clonazepam is even more potent than Xanax or Prazolam. The onset of action is slower, and it has got relatively longer half-life. So it's medium to long half-life. This is very potent, as I mentioned. Diazepam, Valium, it's very, very long acting, although it's rapid, but it's very long acting, and it has got active metabolites, including temazepam, for example. So we have to be cautious. You give diazepam, you're likely to have impact, sedating effects, cognitive effects, longer than intended. Lorazepam, it doesn't have active metabolites. Temazepam is used in the UK as the benzo for insomnia. It's not very potent, and it's got half-life that's short. So that's the idea, is that you don't get hangover effects next day. And then we've got the Z drugs. These are non-benzodiazepine drugs, but they have very similar effects to benzodiazepines because they modulate the benzodiazepine-specific subunit sites of the GABA A receptors. And we've got a number of them. So we've got zopiclone, S-zopiclone, zolpidem, and zaleplone. As you can see, the half-life is generally short, which is always good for a hypnotic, because you don't want someone next day to complain of hangover effects. The S-zopiclone is probably the one that is least associated with dependence, but generally speaking, they are not likely to be associated with dependence. They are not likely to be associated with also patients asking you to constantly increase the dose, but they can be misused. So what the BAP guidelines say that because insomnia can be a long-lasting problem, and if it's working, and if nothing else is working, also, so the patient is doing everything else they need to do, they are not drinking caffeine, not smoking, not using alcohol, having good sleep hygiene, and benefiting from this Z drug, then you might have to accept that they have to use it for long term. And the evidence suggests that tolerance and withdrawal is not inevitable with hypnotic therapies up to 1 year with S-zopiclone and zolpidem. So what they suggest in the BAP guidance, that's British Association for Psychopharmacology, just a reminder, that intermittent dosing may reduce the risk of tolerance and dependence. But really, I want to ask here clinicians, do you prescribe an antihypertensive and just leave the patient without review? Or do you prescribe them a medication for diabetes, any chronic condition? You ask them to come back, you review them, you review the effect of the drug, you review the side effects, you do tests to check for any systematic tests. And the same applies here for insomnia, chronic insomnia. So if you prescribed any Z drug, which we are saying it might be acceptable in certain situations, you need to assess the patient both objectively and subjectively and see their progress. So here about just to show the prescription of the Z drugs. So in over 2 decades, in the 90s and 2000 to 2009. So if we look into the benzodiazepines first, and if we just look into this purple line in the middle. So the hypnotic use of benzodiazepines dropped dramatically over 2 decades. Okay, so we might think, okay, that's good news because people are not using it as much. But if we check for the Z drug, and that's the blue line in the last one, and we see that the sharp increase. But the green line in the middle is the interesting one. So that there hasn't been no change in how much we prescribe hypnotics over 2 decades, which is interesting. So it reflects how much of a problem this is. Now, for other options, we've got melatonin, and melatonin is an interesting one because it can help with jet lag disorder. It can help with delayed sleep phase, so because it reduces the onset latency. And also when you have the non-24-hour sleep rhythm disorder, you know, some people say that my sleep circle is maybe 28 hours. So one day they sleep for between 10 and 6 next day, and that's okay. But the next day would be between 2 a.m. and help me here, 10 a.m. And the following day will be between 6 a.m. and maybe 2 p.m. and so on. So melatonin can be helpful in these situations, in addition to light therapy, in addition to other approaches. It generally is safe. It's not hugely effective. So it has modest effect compared to other hypnotics, you know. And the dose, it is available as a dietary supplement, as you can see in the picture, can be over the counter, can be given to the elderly, can be given to children, particularly those with autism spectrum disorder, sometimes ADHD. You can prescribe it. Again, you have to have the same caution when you're prescribing it, despite it being generally safe. And there is the melatonin receptor agonist, Ramiltion. Again, it has evidence of efficacy in insomnia and not associated with dependence. Similar studies to the S-zopiclone, up to 1 year, you can take it without worrying about too much about withdrawal and tolerance effects. Now, the histamine histamine antagonists, so that's antihistamines. They're available over the counter in the UK. They're available here over the counter, as I understand it. So that led to the perception that they are safer than controlled drugs like benzodiazepines and Z drugs. The actual fact is that actually, because a lot of them have significant anticholinergic effects, which means that they can impact on cognitive function, so deleterious effects, the GI tract effects, cardiac side effects. So they're not really very safe. You know, you can use them sometimes. People use promethazine sometimes. But they also have long half-life, so they might not be really very suitable in many cases. But having said that, selective antihistamines, those pure antihistamines, compared to those who have, which have effect on anticholinergic effects, can be effective and well tolerated as hypnotics. And doxepin, which you might have heard of it as an antidepressant, in low doses, it's a selective, pure antihistamine. So we're talking about a dose of 3 to 6 milligrams, and it's licensed in the US as a hypnotic. So it can be used. It's even the British Association for Psychopharmacology has also recommended it for the use of chronic insomnia. The peak sedative effect is around 90 minutes after the peak plasma level, and useful for sleep maintenance insomnia. So, so you can use it, you know, particularly for people who have maybe mid-sleep insomnia, and particularly early morning awakening, and particularly for people with chronic long-term insomnia. Now,
I'm
antidepressants,
sorry.
I've spoken about,
Yeah.
sorry.
Yeah, sorry, doctor. There are quite a few questions, so if you allow us a few minutes for questions and answers, there are some questions from the audience.
Absolutely. So
okay.
actually, this is my second to last slide.
Okay, all right.
So antidepressants, antidepressants and even antipsychotics, in practice, they can be used, although the evidence is little to support them. They do have, as a side effect, some of them, they have sedative effects, you know, quetiapine, olanzapine, those antipsychotics, antidepressants, like tricyclics, they do have sedative effects. So if there is, for example, psychosis and insomnia, you can think of the best option would be an antipsychotic that has sedative effects. If there is depression with insomnia, then maybe you want to consider the antidepressant that has a sedative effect, and where even with there's just insomnia and little evidence of depression, you can use trazodone, doxepin, as we mentioned earlier, and mirtazapine. These are the three antidepressants that are recognized for this indication. So just to conclude, the sleep disorders are very common. They're common in the general population. They're very, very common in clinical practice. You do need to get a reliable diagnosis of sleep problems, and the management should include sleep hygiene, relaxation techniques, psychological approaches such as CBTI, and appropriate pharmacological treatment. So that's the end of my talk. Thanks very much. I'm ready for your questions and comments.
Thank you very much, Dr. Hamid, for that very, very informative talk. Very quickly, I'd like to start with the questions, and if anyone wants to raise his hand at any time to ask directly, they would be able to do that. The first question, yes,
can
Professor.
I just that because I have another meeting?
Yes, go ahead, Professor.
Okay, so you know, I'm doing two meetings at the same time, but I was really interested in this talk. That's why I'm attending this. Can I ask you, you know, about, you know, now it's COVID, and what do you recommend, you know, for long flights? And what is your experience with some of those, you know, I tried sometime with long flights, the nightmare that are associated with some of these, you know, they gave me Xanax, and then I don't know if that is a common side effect, but the nightmare, I felt that I am going to die. Is that a common side effect for for sleep medicine?
Thanks very much, Prof. Qutaiba. This is an excellent question. Thank you so much. So I think the issue of COVID is very relevant. We know that the immune system needs to be at its best. So I would advise, although this is a theoretical advice, that antihistamines should be avoided in those situations. Although from looking into the literature, there isn't strong evidence to back my advice. It's simply the evidence is purely theoretical, because COVID is only a recent condition that we've had it for nearly a year. So antihistamines should be avoided, in my opinion. The second one, benzodiazepine generally should be avoided. I've particularly spoken about Xanax as not a good choice. So I'm sorry that you were given this. It is associated with side effects, despite having some effects on, you know, making you asleep, but certainly.
What do you recommend for a longer flight? If I want to fly to Australia, you know, and I cannot take, I have no problem with sleep in general,
Yeah.
but I'm just.
Yeah, so my recommendation would be either a Z drug, such as Zopiclone or S-Zopiclone. And we're talking about here, S-Zopiclone probably is even better because it's not, its half-life is not very short. So we don't want something that's very, very short that will disappear off your system before the flight finishes. The second thing that can be recommended would be melatonin. Melatonin is safe. I'm assuming you're above 55, Prof. Kutaiba.
No, I'm less than 55.
Of course not. Of course not over. That's not good assumption, Dr. Hamid. Not good assumption over 55.
Yeah, well, I'm assuming because it's safe even in children. So I'm just,
Yeah, but melatonin, because I tried when I used to go to Japan. Is that a sort of like a different response in different people? Is it more to regulate the cycle or to give you a sleep? I thought melatonin is more about regulating the cycle of sleep and sort of like jet lags. Am I correct? Or
Yeah, no, you're absolutely right. So melatonin is more about regulating the cycle. So it is indicated where there is the circadian rhythm is affected. And it generally, because of the safety of its profile, side effect profile, it is widely available. It has modest effects. So I think in your situation, I think I'm not talking here about the doctor advising a particular case, because that wouldn't be appropriate. But I think from what you presented here, I think the Z drug would be the most appropriate one.
So when COVID-19 sort of go and start to fly, I will come to you. Thank you.
You're most welcome, Prof.
Thank you, Professor. Doctor, we're out of time. There are just a couple of questions that were typed. One of them is actually related to melatonin. And I was aware that it's recently become a controlled substance here in the UAE, and it can only be given by a special prescription. Is that true? And if so, is there a reason behind that? Is it because of a safety issue?
So in the UAE, I'm actually not 100%. As you know, I started practicing only less than 2 months ago, and I haven't prescribed it at all. So yeah, generally speaking, I think from the evidence that it's relatively safe, but I think in some cases, I remember some cases where it wasn't very well tolerated. The issue with it being available over the counter is that it can be in certain situations abused. So I don't think that in the UK they have made it not available without prescription. But I can understand fully why the UAE want to have kind of more stricter approach to this, which in many cases is the right approach, because if it's indicated, let the doctor prescribe it. If it's not indicated, let not anyone just take it, without considering the things that we've said.
Okay. And just to follow up, what would you consider is a safe dose for melatonin if it's prescribed by a non-expert like myself, for example? Or would you suggest I do it or refer?
6 to 8 milligrams would be, 6 milligrams, depending on, are you talking about adults or children or older adults? Yeah, because generally speaking, for children, you want to, and for older adults, you want to use the smaller dose. For adults, you can go, you can have higher doses, but generally, a starting dose of 6 would be very reasonable. Going up to 8, 9 would still be okay. You can go above that, yes.
And doctor, just one last question. This is related to the pandemic. As you know, a lot of people are stressed and worried. And the member is asking, what kind of insomnia do you think this stress and worry would cause? And what can we do to reduce that, the insomnia particularly, because we don't really have control over what's going on?
Well, that's a great question and a great way of putting the question, because starting from where you ended, we have little control over it. I think we need to think about what things we can control, what things we can't control. And it's, we start by controlling what we can control and leaving the things that we can't control to people who can control it, if that's not too philosophical. So starting by the worries, you know, is it that we're worried about getting the catching the virus? So, well, worrying is not going to help. What is going to help is by taking the precautionary measures, washing your hands, wearing your mask, getting the vaccine, getting the second dose of the vaccine, getting tested, following the rules and regulations. Okay, so that's kind of if that's what you're worried about. If you're worried more about kind of financial or not socializing, not being able to fly because or despite you having urgent causes for this, then you address that. But my kind of general advice to this is that it's about how you manage things. Yeah, sometimes if you're overthinking of it, and if you're if you're more worried about it, you're more likely to make mistakes that you regret later. So if this is anxiety, if this is depression, probably I would say speak to the doctor, get help. It might be medication, it might be not medication, like cognitive behavioral therapy. But I think this is really, really important. Sleep is very common. Sleep problems are very, very common in many sorts of situations.
Thank you, doctor. And I have a personal question, and this might be relevant to those who have children. Now, you know about, Atarax hydroxyzine, which is one of the antihistamines. And I'm not talking from personal experience. I've never used it, but sometimes it's been used, to get children to sleep, whether it's at night or when you're traveling, to keep them a bit more sedated. Do you support that at all? Are there any dangers associated with that? Would you say, no, this should not become a practice and no one should give an antihistamine for this purpose, for children specifically?
So I think it depends on how you justify it. So if it's to get them to sleep, probably is not a good idea. And I mean, children, anybody less than 18 would be a child. So are you talking about children of which age?
Well, you do have cases of actually abuse of Atarax itself as a medication to get the children to sleep, not just by parents. So I wanted to know your opinion about this, and would you say no, definitely antihistamines should not be used for this purpose?
So antihistamines, they come with all sorts of problems, and even a high dose of antihistamine can actually can be lethal. If you're talking about a small child and you've given them 10 times the dose, then you're risking their life. So this is not the fact that it's available over the counter doesn't mean it's safe. I think I've covered this point. And in children, we prescribe based on not just age but weight, and we have to be careful. We have to think about the side effects. So I think you do have to be very careful when giving antihistamines to children. If it's about trouble sickness, then maybe it's not the antihistamine is the medication that you should give. Think about what would be the best. Getting them to sleep. Are there any other ways to get them to sleep? Is there any colic pain? Is there any, are they hungry? Are they thirsty? So making them sleep is just shutting them off without realizing their needs. So that would be my message. I hope I haven't been too harsh on parents. You know, I
No,
know that they
again,
want the best for their
I
children.
want to repeat, this is not personal experience. I have never done that, so I don't want anyone to get the
Yeah.
wrong impression. I know we're out of time, but this is a very interesting topic, and I don't know if sleep paralysis is goes under your topic, but you know how it is when you just wake up and you're unable to move. Is that something that is common? And how long would you normally expect that to happen when you wake up in the middle of the night and you have that worry you're not able to move your arms and your legs, and you may panic? And this
No,
is from
that's an
personal
excellent
experience.
actually question, and this is something I usually cover in my kind of you know, when I'm teaching students. But this is in outside kind of the this type of lecture. So sleep paralysis, if it happened once or twice, is not a problem. Usually, the trigger would be either stress or it would be sleep deprivation. You know, someone who has exams, not been sleeping because they have to revise. So it's not a worry. It is very, very frightening as an experience to the person who has a sleep paralysis. But what I'm saying, if it happened once or twice and there was an obvious trigger, either stress or sleep deprivation, then address the stress and sleep deprivation and reassure the patient. If it happens repetitively, then in that case, it becomes more of a problem, and there is medication for it. It's about, you know, it can be to do with the serotonin. So, so treating with the right medication addressing the 5-HT receptors would be a relevant one. But I think, you know, this is something I would like the person to get help for instead of you know, just getting anything over the counter for it.
Okay, thank you very much, Doctor. I don't see any more questions, so I will end the session here. And I would like to thank you for accepting our invitation and coming today.
It's my absolute pleasure.
All right.
Thank you so
Thank
much
you.
for the invitation.
Assalamu alaikum, and thanks for everyone who's joined us today as well.
It's,